KSOS and Dr. Bastin for giving me the opportunity, that is the OCT Masterclass for comprehensive ophthalmologist. I invite all the speakers to come on to the stage. So as you know, OCT is the most important investigation in all the retinal diseases and the glaucoma, early detection of glaucoma, and the recent advanced OCTA, which in some patients whom the FFA is contraindicated. OCTA can be used as an alternative. So straight away we can start the session. First I call upon Dr. Dhanya for her talk, how to interpret a normal OCT.
Thank you, ma'am, for this opportunity. So this class is how to interpret a normal OCT. OCT has revolutionized the diagnostic field of retina. It is actually an in vivo optical biopsy, and the spectral domain OCT gives high resolution, accurate imaging of the retinal layers. These are the various modes of OCT that we had. Now presently we have the spectral domain OCT and the swept source OCT. It gives you a qualitative analysis as well as a quantitative analysis. It helps in identifying the anomalous structures, the location, form and structure of the lesions and reflectivity of the layers and lesions, as well as you get a thickness and volume measurement. Now, considering the location, it could be a pre-retinal, epiretinal, intraretinal or subretinal and sub-RPE, and the reflectivity depends on how much pigment it contains and whether the orientation is horizontal. So if there is more pigment, more horizontally oriented, we get hyper-reflective, which are white or bright. Now this is the OCT nomenclature. The most important thing that when you have to remember when you look at a normal OCT is that the four hyper-reflective outer retinal layers. The most important is the RPE Bruch's membrane complex, then the external limiting membrane, the ellipsoid zone and the interdigitation zone. In the inner retina, we have the hyperreflective layers, which are the neuronal layers or the plexiform layers. The nerve fiber layer, the inner plexiform and the outer plexiform layer. Now, based on reflectivity, that is how you identify the lesions as well as the normal structures in OCT. The high reflective lesions are pigments, scars, hard exudates, drusen, hemorrhages, all these are hyperreflective. Medium reflectivity is for retinal edema, fibrin and posterior vitreous, and low reflective is fluid or vitreous. As in the picture you can see the hyporeflective cyst and the hyperreflective hard exudates. Now what is this? This is shadowing. Suppose there is a hyperreflective lesion or in the inner layers, it can produce a shadow onto the posterior layers. That is called shadowing, which usually we find when you look at hard exudates. Now, this is reverse shadowing or windowing, that when there is a large area, as in case of an AMD, when there is a large area of geographic atrophy, you can see that the choroid is more visible. This is called windowing or reverse shadowing. What is this picture? This is asteroid halosis casting its shadows on the retinal layers. In qualitative analysis, when you look at an OCT printout, you have a macular cube or the ETDRS grid, which gives measurement of certain areas of the macula. It is divided into the central subfield, which is 1 millimeter, the inner macula, which is 3 millimeters, and the outer macula, which is 6 millimeter. And the thickness of this is measured from the internal limiting membrane to the retinal pigment epithelium, which is given as a value on the OCT printout. These are the scan protocols that you have in spectral domain OCT, the macular cube, the radial line scan and the high definition raster scans. These are few images from the Cirrus OCT. You can see both macular cube and the high definition images. Spectralis gives a more wider view and a 3D volume scan of the posterior pole. Atlantis pictures. Now, when you have an OCT printout in your hand, it's always important you analyze the OCT from the machine itself. But if you are getting a printout, look at the patient details, the eye, the dates, if it is a serial scans, confirm the signal strength, at least 6 out of 10 is present, and is the image well centered on the area of interest. A printout in hand. First you have, this is the LSO fundus image with the ILM RPE retinal thickness map overlay. the ETDRS grid, the OCT fundus image, the OCT image which showing the horizontal crosshair line and the vertical crosshair line. You also have the 3D macular thickness map showing the retinal thickness in a topographical display, a segmented ILM map and a segmented RPE map, plus the macular parameters compared to the normative data. These are the high definition images. You also get a macular change analysis report. This is very useful when you are following up a patient which is treated. You may also get a single eye summary like this, where you have both the macular analysis as well as the ONH RNFL analysis. Now, for reading a normal OCT, always look at the normal, look at the vitreoretinal interface, whether it is normal, the foveal contour, whether the layers of retina has a normal morphology, ellipsoid zone, and the RP Brux membrane complex. These are various OCT reports. We'll have a detailed discussion later. And OCT is very important in diagnosing, treating, and following up patients with diabetic macular edema, AMD, as well as and various other conditions, macular conditions. A word on optic nerve, RNFL OCT. It is very important for the management of glaucoma. It is an important adjunct to visual field testing in the treatment of glaucoma, especially in pre-perimetric cases. It can track the optic nerve edema as well. And this is the RNFL OCT and ONH OCT printout. The key parameters result will be given in the center compared to the normative data. This is the RNFL thickness map. So if we have an hourglass shaped map with yellow and red colors, is typical of normalized. The RNFL deviation map, the NRR thickness profile, the TSNIT graph which give you the average thickness, the horizontal and the vertical B scans, and the RNFL calculation circle. Thank you.
Thank you, Dr. Dhanya, on that normal OCT interpretation. Now we proceed to pathological changes in OCT in macular diseases by Dr. Indu. She is the consultant. She is consultant in Vitreoretina at Chaitanya Eye Hospital and Research Institute, Kottayam. On to.
Good morning, everyone. So Dr. Dhanya has very nicely explained the OCT in a normal retina. Now I'll be discussing on pathological changes in OCT in macular diseases. So retinal pathology in OCT, the interpretation depends on two things: how much light is reflected and how much light is transmitted or blocked. There will be a little bit of repetition from the previous presentation. So how much light is reflected is called as reflectivity, and reflectivity can be a hyporeflective or a hyperreflective. Hyperreflectivity indicates that it reflects less light than surrounding tissues and it appears black in color. It is mostly indicative of a clear fluid. This fluid can be seen in the retina, intraretinal, subretinal or sub-RPE space. Hyperreflectivity means it reflects more light than surrounding tissues and appears white. It indicates mostly solid lesions and even turbid fluid. So it could be due to hard exudates, calcification, pigments, fibrosis, preretinal or subretinal membranes, anything solid or turbid. Now, how much light is blocked or transmitted causes shadowing or reverse shadowing. So if a lesion absorbs all the light that falls on it, it causes hyporeflectivity posterior to it, and that is called as shadowing. And if there is thinning, it allows more light than normal to pass through it, and it causes hyperreflectivity posterior to it, and that is called as reverse shadowing. So reverse shadowing indicates thinning. Now coming to analysis of an OCT pathology, as Dr. Dhanya said, it has to be gone in a very systematic manner. First you look at the retinal profile, then the fovea, and then a layer by layer analysis. So retinal profile, it can be abnormally concave or abnormally convex, abnormally thickened or abnormally thinned out. A retinal profile which is more concave than normal, it indicates usually a posterior staphyloma in high myopia, whereas abnormal convexity indicates tumors, scars, or even a dome-shaped macula. So retinal profile gives a clue to a diagnosis. So if you find an abnormal concavity with a subretinal membrane, that indicates it is a myopic CNVM. Abnormal convexity with a little amount of fluid on the top might be due to dome-shaped maculopathy. If you see an abnormal convexity with choroidal folds, might indicate a posterior scleritis. Now coming to thickness, you can have thickening or thinning of the retina. It can be localized or generalized. A generalized thinning indicates usually ischemia, as in case of an occlusion, whereas localized patchy thinning might indicate a age-related degeneration or a central serous retinopathy. And focal thickening can be due to localized edema or focal traction, whereas generalized thickening is usually due to preretinal membranes causing a very broad traction on the macula. And after that, you go to the foveal contour. So normal foveal contour can be blunted or you can have defects. A blunted foveal contour with severe visual abnormalities is usually seen in foveal hypoplasia. So here you can see there is complete absence of foveal depression, and it is commonly seen in hereditary disorders like albinism or aniridia. Whereas if you just see just a blunted foveal contour without any significant visual abnormalities, it is called as fovea plana. It is normal. Now coming to defects at fovea, you can have full thickness defects, and that is called as a full thickness macular hole when there is total absence of all the neuroretinal layers. Whereas if the defect is partial and only involves the inner retina without involving the outer retina, that is called as a lamellar hole. There are two types, a traction one which is associated with an ERM around it, which causes traction, tangential traction, and causing inner retinal layer splitting, as you see here. Whereas the other one is called as a degenerative LMH, when you see degeneration of the layers which is causing the lamellar defect. Now coming to layer by layer analysis, so you go from anterior to posterior. So in the vitreous you can see a few abnormalities in the vitreous itself. Like for example, you can see a membrane which is attached to fovea, which is the vitreous membrane. A silicon oil reflex on the right side. You can see dot-like opacities which could be asteroids, hemorrhage, or witch cells, and even an operculum overlying a full thickness macular hole. Then you go to the vitreoretinal interface. So in vitreoretinal interface, three things are the common ones. One is the preretinal membranes, most commonly vascular membranes, causing a very broad traction. You can see the traction of the disc also. The other one is an idiopathic membrane. You can see just a small membrane over the macular region, or you can see that the vitreous is causing a vitreous membrane which is causing a focal traction of the fovea, which is called as vitreomacular traction. So preretinal membranes are usually proliferative membranes. They are very broad. They cause a very significant traction which can cause retinal layer changes and even submacular detachment. In VMA, you find that the vitreous is attached at the fovea alone, but it is not causing any anatomical changes. That is called as vitreomacular adhesion. But sometimes it causes traction on the central part. You can see a small tenting at the fovea. You can see pseudocyst at the fovea. You can see inner layer schisis in the fovea, and even a submacular detachment. And that is called as vitreomacular traction. Now coming to idiopathic membranes are seen as a thin hyperreflective membrane over the macula. If it is not causing any change in the foveal contour, it's grade 1. If it is causing slight flattening of foveal contour, it's grade 2. If it is causing an ectopic inner foveal layers to migrate to the center, that is called as stage 3. And stage 4, when you find that there is total disorganization at the fovea. Now sometimes you can have a tangential contraction of the fovea which causes steepening of the foveal contour, and that is called as a pseudo-hole. Pseudo-hole appears like a hole, but it is not a hole. And usually vision is not much affected in such cases. Sometimes what happens is that the ERM contracts and the fovea gets pushed out through the opening, and this is called as foveal herniation. That is also sometimes seen with an epiretinal membrane. Now coming to inner layers, you can have three important problems. One is hypo, hyper, and disorganization. Hyporeflective can be due to cystoid edema when it is more round in shape, inner retinal schisis which is more column-like, or a moth-eaten appearance. You see cavitations which are seen in macular telangiectasia. And inner layer hyperreflectivity due to something deposited there, solid lesions. It could be hemorrhage, it could be pigments, or sometimes when you see the last picture, you see there is a diffuse inner layer hyperreflectivity, which indicates hypoxia, as in case of a CRAO. And you can have a complete disorganization of inner retinal layers, which is called drill, and drill is commonly seen in DME and RVOs, and it indicates significant ischemia. Now coming to outer retina, two important things that you have to look for, that the bands and deposits. In the outer retinal bands that you have to see are the external limiting membrane as well as the ellipsoid layer. It could be intact, it could be disrupted. So disruption is commonly seen in MACTEL, CSR, post-trauma cases. And sometimes you can have a diffuse thickening of the ISOS junction, which can be seen in Berlin's edema. And deposits are usually outer retinal tubulations, which will have a hyporeflective center with hyperreflective borders. Should not be mistaken for intraretinal cysts, and they are associated with subretinal fibrosis. Now coming to the, so you have finished the retina, now you go to the subretinal space. So again in the subretinal space you have two important lesions, hypo, hyper. Hypo usually indicates clear fluid, commonly seen with CSR or sometimes along with the neovascular membranes. Hyperreflective indicates again a turbid fluid, which might be a fibrin CSR. You can have deposits, vitelliform deposits, or you can have a thick membrane in the subretinal space. This along with intraretinal fluid or subretinal fluid. And after you finish the subretinal space, you go to the RPE. So RPE can be elevated with a clear space underneath, which indicates a serous PED. But if there is something deposited there or a hyperreflective material underneath, it indicates more severe problems. It could be due to drusen. It could be sub-RPE blood. Sub-RPE blood causes shadowing posteriorly. You cannot see anything behind it. It could be a sub-RPE membrane. Membranes can have associated shrum and associated fluid. Or you can see sub-RPE polyps, which are actually hyperreflective material under a thumb-shaped polyp or a notched PED. And RPE could be diffusely thickened, as in case of a scar, in which case you will see a lot of intraretinal changes above it, or it could be generally thinned out, as in case of a geographic atrophy. And then you go to the choroid. Choroid can be measured into the EDI. You can see all three layers of the choroid. And in the choroid, you have to assess the thickening and the thinning. Thicken in case of pachychoroid diseases, inflammatory lesions, and tumors. And thinning can be seen in elderly and myopia. You can also make out a few abnormalities like a choroidal cleft or a choroidal fold. So the take-home message is you have to evaluate all the layers. You have to scroll through the raster and classify the abnormality accordingly. Thank you.
Thank you, Dr. Indu, for that wonderful presentation with excellent pictures. Now we move on to the next talk, that is OCT in glaucoma. As you know, initially the visual field interpretation is the most important part in treating, when to treat a glaucoma, but you know that 30% of the visual field should be affected to get a positive finding in the visual field. When OCT comes, the term, the pre-perimetric glaucoma came. So the importance of OCT is very important in treatment of glaucoma in the current scenario. Over to Dr. Jayasri, who is the Senior Consultant at iVision Hospital, Thrissur.
Thank you. Thank you, KSOS and Mallika Madam, for the opportunity. So the presentation is on OCT in glaucoma. So OCT is useful in multiple aspects of glaucoma, mainly the optic nerve head and OCT evaluation of the RNFL. Anterior segment also the OCT is important, especially in the angle assessment. And OCT angiography is also important to identify the pathology of vascular supply of the optic nerve head and the choroidal supply also. And coming to the proper heading of optic nerve head and RNFL, pre-perimetric glaucoma, as madam has just mentioned, up to 4 years before the earliest visual field defects happens, RNFL defects tend to happen, and that is where we can earlier catch this glaucoma. It is especially useful in suspicious optic disc with normal visual fields. Here what we see is there is a suspicious disc, and if you ask me, there is a suspicious visual field defect. So to make sure whether there is an RNFL defect or whether it is glaucoma, we do an RNFL analysis, and then you see that there is an infratemporal RNFL defect, and then your diagnosis is really clear here. So it is very important to correctly identify and interpret the OCT printout. Here I am going to interpret a serous HD, OCT, optic nerve head and RNFL, and most of the other RNFL and other printouts are analyzed in a similar way. So it has 9 parts. So why do you have to systematically interpret an OCT? It is first one, not to miss the small details, and it is important in final decision making. You have to identify artifacts and anatomical variation so that misdiagnosis is avoided. So these are the 9 parts that you have to remember. It is very important not to just look at these 2 diagrams, these 2 pie charts here and diagnose glaucoma. That is not sufficient. So there is a color coding, as you can all see, and this color scale is a comparison of the thickness of an individual's measurement against the normative database. Green is when you lie between 9 to 95%, yellow is between 5 to 1%, and if you fall below that 1%, that is when it is 1%. If you are not gradable, it is in gray, and if your thickness is more, it is white. So patient data is always important, signal strength most important, so it comes in the first portion, and date of birth most important because it is against this age match that every normative data base is compared against. Signal strength, so beyond certain signal strength, it is not very useful to compare that data. So multiple machines have multiple signal strength, and beyond which data it is acceptable. Look at these values, more than 6 in Cirrus OCT. Spectralis, the quality score has to be more than or equal to 15, and OptoView, the SSI is more than or equal to 30. So coming to this key parameter, the key parameters are given side by side, and you can compare with both the eyes. And this is again, you can see compared to the normative database and is color coded. RNFL thickness map is something that is exclusive for this Cirrus OCT machine, and this is what you call falsely color coded. This raw RNFL thickness data is given. What you see as cool colors are where the RNFL is thin, and the warm colors are where the RNFL is thick. This is not compared to the normal database. If you see black areas in this RNFL thickness map, those are the areas which are not used for data analysis. If you see, this is the neuroretinal rim thickness plot. What you see here is in the TSN90 configuration, this neuroretinal rim is measured between the Brooks membrane opening, that is the border of the optic nerve head, to the border of the optic cup. And you can see that this again is age and disc size match, and is compared with the normative database. Everywhere the data are given together, or because the symmetry can be analyzed. It is very important always to look for the symmetry of the eyes in glaucoma, and also the size of the disc. RNFL deviation map is something that is very important. The measured RNFL thickness is shown, and you can see these yellow areas. This is less than 5%. If it comes in red, this is less than 1%. Where is this RNFL thickness measured around the optic disc? It is at 3.46 millimeter. This circle comes around 3.46 from the center of the disc. You can actually calculate, you can actually move this manually, this circle manually, but the normative database comes for 3.46 millimeter value only. The RNFL thickness Tissen plot is seen like this. The RNFL thickness at each location along the calculation circle. If you open up that circle and stretch it on an x-axis, this is how it looks like, and you have double hump pattern here, and that is because the superior and the inferior RNFL is thicker than the nasal and the temporal. It is very useful in detecting the earliest thickening. So if you always look for this tracing, if there is a localized thinning here, that is more indicative of a RNFL thinning localized. These summaries of the RNFL thickness are given in the quadrants and the sectors here. Again, these are the B scans that was already told, and this is to make sure that the cup configuration is appropriate. And this is the OCT image calculation circle, just to make sure that there are no PVDs which are causing green disease. Green disease I'll come to later. So this is how a normal and an abnormal, normal and a glaucomatous OCT looks like. This is glaucomatous where you have cooler colors, where the key parameters you can see are in red, and you can see the RNFL deviation map showing red colors. The NRR thickness has come down, RNFL defects, RNFL thickness has come down, the pie diagrams are also affected. So these many changes you can see in a glaucomatous OCT. So many changes have to be looked for. Yes, GCC is very important in glaucoma because very low variability. GCC is something that is getting affected even earlier than RNFL. It is important to image macula for glaucoma because it has low variability, less prone to artifacts and anatomical variation. But one limitation is that glaucoma is a disease of elderly, and when you become elderly, they can also have macular diseases, so that can affect. So GCC also you can interpret based on the similar lines. You have this thickness map here, deviation maps, and these parameters also follows this color coding and the age matching. Coming to normative data, it is the axial length that is covered in normative data is between -12 diopter and plus 6D, and axial length is from length 22 to 28 millimeter, and beyond this, the highly myopic and hyperopic are flagged as abnormal. You have to see this age group. Less than 18 is not there in the normative database, and Indian eyes are not much studied in other type of SD-OCTs and all. So what you see, if the patient's age is less than 18, the type of OCT printout that you get is not with this color coding that you see here, but without a color coding. But is it still useful? Yes, it is still useful because you can use this same OCT to compare the progression of the patient. Even if he is less than 18, the same patient can be compared for progression with his own OCT. Are there any limitations of OCT imaging? Yes, because it needs clear media for good quality scans, cataract, corneal opacities, vitreous hemorrhages, and all this can lead to misinterpretations. Highly myopic eyes have more issues with that because poor quality imaging can be the segmentation errors, dissimilar reference database. So the alignment can be completely different. The calculation circle, that 3.46 millimeter calculation circle that we have taken, all those could be at TETOS. What is something very important is called as floor effect. If the glaucoma is very advanced, OCT becomes very less useful, especially beyond the HFA of -10 to -15 decibel. Tissues other than the RGC axons also contribute to RNFL thickness. That basic tissues does not die off, so that is the reason why you still have floor effect. RNFL thickness gets flat at 30 microns, and if your RNFL thickness goes beyond 30 microns, if it falls less than 30 microns, then that is a false reading. So red disease is something when you have false positive diagnosis. If there is no disease and the OCT machine finds out disease, that is red disease. If there is disease and the machine says false negative diagnosis, that is what is called as a green disease. So red disease usually happens in myopia. This is an example of green disease. Actually there is disease here, but because of averaging, that disease is not seen. So cataract leads to RNFL, gross RNFL thickening. So these are examples of red diseases, abnormalities, media opacities. Here there is a V's ring that is producing black spots which cannot be used. This is a myelinated nerve fiber. The calculation circle is wrongly found out here. Hemorrhage, which is found as a red area, which is thickened area. You can see that RNFL is. So we cannot use interchangeably. So the points to take home are: image acquisition with dilated pupil is always better. Allow the patient to blink and apply lubricants because signal strength is very important. Pay attention to scan quality before interpreting. Systematic approach. Always come from top to bottom. Combining RNFL macula and optic nerve head parameters improves the diagnostic performance. Always clinically correlate with the HFI. Sequential OCT is important in progression analysis. SD-OCT machines have similar diagnostic abilities but not interchangeable. Thank you.
Thank you, Dr. Jayasree, for that important stepwise. Actually, it is very difficult to get this stepwise interpretation of the OCT. So, It is very important, and as Dr. Jayashree told, OCT is of no much use in very advanced glaucoma. It is actually useful for early glaucoma and in the pre-perimetric glaucoma, and used for follow-up also, but not much importance in late or advanced glaucoma. Now we proceed to the next talk. The next two talks are by Dr. Mahesh. Use of OCTA in current scenario, OCTA, and followed by the rapid fire quiz. Okay, over to Dr. Mahesh.
Thank you. Hall നല്ല തണുപ്പായത് കാരണം ഞാൻ അവിടെ ഇരുന്ന് ഉറങ്ങായിരുന്നു. So most of you. Anyway, I will talk about OCTA in the current scenario. OCTA is there in many centers now and it is being used. OCTA has not replaced the OCT, dye angiography in our management of retinal diseases. So we'll go through some of the why it is not replacing OCT, dye angiography. Because if I ask which is the abnormal vessel, which is mature vessel, inactive vessel, can you tell which is leaking vessel? It all looks like the same. Some are thin, some are big, some are small bunch, some are large network. So it is very difficult. It is just looking at the menu and ordering in a Chinese restaurant. So it is extremely difficult. So that is why we don't use OCTA alone unless you are very expert and you know what to look for. So there are different types of networks seen in OCTA, in AMD, Medusa head, C-fan, prune tree, and mature trunks. Lot of types of vessels are there. So let me tell you that there are type 1 CNVM or MNV, macular neovascularization, type 2, type 3. Type 1 is sub-RP, type 2 is pre-RP, and the other one is third, type 3 is RAP, retinal angiomatous proliferation, where some things are happening in the retina down. So these three will have different findings. Like this is a in the OCT, you can see a hyperreflective double layer sign in the upper left, this thing. And where there is a hyperreflective double layer sign, there is a network underneath, which is having a medusa pattern in type 1 CNVM. So this is another case of type 1 CNVM. You can see a thin filamentous network with surrounding halo or hyperreflective area, which is due to some fluid around. So the vascular density is very high, unlike a mature large trunk where vascular density is less. Okay, so this is type 2 or pre-RP. This will be, the network will be growing from under the RP to the pre-RP space. So it will be a small bunch, but very dense. You can see that it is a small bunch, but very dense with more SRF and subretinal and intraretinal fluid. So this is a classic CNVM, old terminology, classic CNVM. So you can see after injection how the vessels have changed. It has not disappeared, but it has reduced significantly after the injection. Then type 3 is RAP, where there is a medusa head. You can get the, actually RAP also you can diagnose with OCTA, where there is a clinical signs and OCTA. So this is how we use OCTA. After 3 injections of anti-VEGF injection and 3 anti-VEGF injection, you can see that vessels have become less, the network have reduced, vessels have become more stouter and larger, so it's becoming a mature vessel. But when the reverse, PCV also can have different patterns in OCTA. You can get a network as I showed in the hyperreflective double layer sign, and it is little difficult to get the polyp in PCV because at the thumb-shaped PED tip, there will be a polyp which may not be high flow. The flow in the polyp may not be high, so that the OCTA may not show the polyp very clearly. But you can get the polyp as it is seen in the right picture. So we use it for follow-up when there is no activity. The top one has no activity. I don't have the OCT picture corresponding. No activity. It's a large mature trunk. OCT is dry. The next one, you can see that network has become more filamentous area, more thin vessels are growing, vascular density is increasing, and correspondingly you can see that IRF has started. That is activity. So you inject again. So this is worsening. after in OCTA. So this is a very useful tool for follow-up. That is what I want to tell. So you don't have to repeat angiogram every time, and you know which patient to go to treat and extend regimen and which patient you can use on PRN based and all. So very useful. So that this is the main thing that we are using in neovascular AMD and PCV. Now I will tell some other classic uses of OCTA. You can easily detect ischemic maculopathy if it is RVO. If the patient has, we cannot do dye angiogram. We don't do dye angiogram very frequently in RVO and all. So you can have some biomarkers in OCT like this drill. The top picture left side, you cannot make out the layers of inner retina. So there is a disorganized retinal inner layer, and in fact that corresponds to the superficial and deep vascular plexus network abnormality in OCTA, which you can call it ischemic maculopathy. PCN or pachychoroid neovasculopathy is a condition between pachychoroid pigment epitheliopathy and PCV, polypoidal choroidal vasculopathy. So sometimes it may be looking like a CSR. This is a case where you can see that it's only looking like a CSR, but there is a large vessel there, the arrow is there. So at that area you can see a clear network of vessel. So there is an underlying pachychoroid neovasculopathy which is somewhere between the PCV and CSR. This is very useful indication, that is myopic CNVM. The classic investigation to diagnose a myopic CNVM is dye angiography. So you can see a nice hyperreflective subretinal lesion, and in the angiogram it is profusely leaking, which after injection it reduces. But the OCTA is equally useful, which shows the network very nicely, and after injection the regression and the mature vessels are seen. So in active myopic CNVM and inactive myopic CNVM, OCTA is a very useful imaging tool. So active myopic CNVM is the top left and inactive myopic CNVM is right side down. So this is a very useful in follow-up. Unexplained visual loss in diabetic retinopathy with nephropathy. As I told in the central retinal vein occlusion, RVO, here also you can easily diagnose ischemic maculopathy, which is the cause for unexplained loss of vision as the old teaching goes. So that is one. Then there is something called non-exudative CNVM, which can be detected only by OCTA, not by dye angiogram, because it doesn't leak. There is no exudation. So this was a case left, both eyes had CSCR, pachychoroid spectrum. One eye had chronic CSCR-like picture, and that eye was having injections. The other eye also had problems. So left eye, already multiple doses of anti-VEGF Eylea was given, and the vascular, but in the other eye, where there was no fluid, clinically, there was a network. It's a silent network. Though this is an indication that this patient also will go for macular neovascularization and defective vision, so they have to be followed up very frequently. CNVM in CSR is another thing. Already it is in the same spectrum. Sometimes where there is a diffuse leak, it's not a typical ink blot or smokestack, and there is some irregularity in RP, you can get a network underneath, somewhere between CSCR and PCN. Multifocal choroiditis, these are all rare causes. All these cases, this inflammation, the problem is in dye angiogram, there will be lot of leakage due to inflammation itself, like disc leakage and other vasculitis leakage. You don't see whether there is any network. So in inflammation like this, the network can be very clearly seen with OCTA. So this is in angioid streaks, very useful investigation. Angioid streaks, you can get a nice specific type of network. VKH with, these are all very, very rare things, but if you want to differentiate that there is something, if there is a hemorrhage which we don't get in ordinary VKH, you can get that network here, and it is. So in toxo, this is a very rare case, but when you see a hemorrhage in a toxo scar, there could be a neovascularization which can be confirmed by OCTA. So these are the type of this thing, angioid streak, another one more angioid streak. So this is the leakage, very small leakage, which you can get. Very rare causes, one coloboma with edge, one exudation is there in that area, The angiogram is showing some diffuse leakage. You're not sure what it is. What in the octa, you can see a network at the edge of the coloboma. So current uses of octa are follow-up of neovascular AMD and PCV, very useful. PCN diagnosis, non-exudative CNVM, myopic CNVM, where you cannot do dye angiography in ischemic maculopathy. And when the leakage is very indistinct and uncertain, like some inflammatory pathology, you can find the network. So these are the uses of octa in the current practice. Thank you very much. Any questions? I can go to this is not a quiz like what you had in the morning, exciting quiz. Everyone can participate. I have few slides. Anybody, Gopal cannot open his mouth. He has come. Okay. So pointer, so I will show some pictures and audience can participate in this. So, very simple questions. What is the sign seen in OCT and which is suggestive of macular ischemia? I just told you. Okay, so this is the outer plexiform, outer nuclear, inner plexiform, inner nuclear layers cannot be traced in the OCT scan. So it is called disorganized retinal inner layers. This is a sign of ischemic maculopathy. You can even avoid, that could be the cause for defective vision in spite of good response to treatment with anti-VEGF. So that is drill. So all of you should be able to diagnose this in OCT. Just take first of all, when you take an OCT picture, OCT test, please look at the black and white picture, not color picture. Okay, the green one will not give you this much clarity. So it is very difficult to trace in a pseudo-colored picture. So look at the black and white picture and always see multiple layers. That is one advice. Don't look at the one printout and say, a lot of people are treating many diseases just with the printout. Just like our glaucoma persons are telling, don't treat based on one picture only. So you need a, so that is drill. So this is which condition? Erosion sign or flap sign. There is a, in the octa there is a small network, right? The right side. Yeah. Pointer. So the RP there is erosion and in front of that there is a subretinal hyperreflective area with fluid. So this is as I told some time back, this is very characteristic of retinal angiomatous proliferans or type 3 MNV. Okay. So basically the retinal new vessels start from the retina, grow inside and there is a discontinuation of the RP. So that is called, it is called erosion sign or flap sign. What is typical sign seen in SDOCT which is characteristic feature of very simple questions. What is the typical sign seen in SDOCT, which is one of the characteristic feature of PCV? Is it serous PED, hemorrhagic PED, thumb-leg PED, RP undulation? So this is what I said. Okay. So TLP, thumb-leg PED, is very typical of polyp. Actually, when you see a thumb-leg PED, the upper part will have some hyperreflective area. Actually, the polyp will be in that area. One more thing that I want to tell is, usually polyp will not be alone. There will be a branching vascular network underneath. So when there is a PED and there is a double layer sign, under the double layer sign, there will be network. Under the thumb-shaped PED, there will be polyp. So when you do angiography, you can easily correlate with that. So this is a typical sign of PCV. What is the possible cause of sub-RP area? This is what just I explained. What is this? Sub-RP, this is a thumb-shaped PED. Just under the RP, there are some hyperreflective area. What is this? Is it hemorrhage? It is not blocking, reduced backscattering is not there, so it is not. So is it outer retinal tubulation? No, I will show some other picture of outer retinal tubulation. So this is the neovascular complex or the polyp where it is there under the RP. So that is the hyperreflective area in the sub-RP area is in PCV is due to neovascular complex. Any comments or anybody in the panel you can contribute to this? Otherwise it will be a boring thing. Then yeah, anything? I am just showing a lot of pictures so that you can have some. So extra large PED, like it is not shirt size, XL sized PED. Where will you get? Again, everything extra large is in PED, in PCV. So huge pigmental detachment is very characteristic in PCV.
And will you call it as extra large?
That because it is not small. Something we have to tell now. I will get another question for you. By definition, what is extra large pigmental detachment? So you can 550. Actually, this it is taken from some studies. This answer is B. Okay, why it is B, I don't know. Somebody has used it in. So basically, it is more than 500 to 1500 microns height. So it is a. This is not a typical hemorrhagic PED. It's due to a large size that you don't see anything under the choroid. So that is extra large PED. So what will be the feature of branching vascular network on SDOCT? Just now I explained. This is a thumb-shaped PED and this is branching double layer sign. So double layer sign can be of two types, hyperreflective double layer sign or hyporeflective double layer sign. If it is hyperreflective double layer sign, it is typically seen in PCV and there will be a branching vascular network here. In hyporeflective double layer sign is usually seen in CSCR where this will be only fluid. Okay. So that is, so it is double layer sign and their BVN will be under this. What is this? What is this? You can see that this is the RP, it is going up and then suddenly it is coming down like this. And this area, there is increased backscattering. So there is no RP, that is why it is increased backscattering. And so this is the classic.
Yeah, the clue was in the previous slide actually. The last,
it was there in the previous slide.
Yeah, yes.
Here, RIP was there? No. Clue was there. Okay. So this is a classic RP RIP, okay. So RP RIP, this area is denuded RP. So there is no RP here, you can see the choroid and sclera later. So this is folded to this area. So that is why this area is a classic RP RIP. Okay. So if you treat the patient and get a RP RIP, you have to continue treatment. It is only a event that has modified the outcome. That's otherwise the treatment there is no change. What is pointed below? What is this? What is this? Sorry. What is this? This is classical. It is seen in chronic cases. Okay, chronic MNV cases. So it is round and it is not like a typical intraretinal cystoid. It is hyporeflective foci, degenerated photoreceptor. Actually, it is the outer retinal tubulation where the ILM has retracted and become round. So this is called ORT. ORT can be in different layers. So this is outer retinal tubulation. It is a bad sign because the visual outcome and treatment outcome may not be very good. So this is ORT, outer retinal tubulation. What is shown here? This is spongiform edema, large cystoid edema, then serous macular detachment, and tortiloid. What is this? This is the classification of OCT, okay? OCT classification. And these are indications of anti-VEGF therapy, but usually in this condition, anti-VEGF will not work with tortiloid. A worse prognosis usually also is in cystoid, and this is the best prognosis. Others will have a little worse prognosis. So this is the answer is OCT classification of DME. Which of the following DME will be the most suitable for focal laser? Focal laser. Okay, lot of hard oxidates. Cystoid changes. Cystoid with serous macular detachment. And this is spongiform. It is said that when there are circinate with hard oxidate, you laser the microaneurysms in the center, it will respond best. So that is what we give focal laser when there is a lot of hard oxidates with leaking microaneurysms in the center. So others can also, but this is just a point to take.
Sir, which was better, sir?
Which one? This one, actually a lot of hard oxidates are there, no? You can do an angiogram, and usually there will be large microaneurysms causing leakage. It is not like the diffuse macular edema, the hard oxidate may not be that much. It is not a rule, but I am just telling. Yeah, Danya.
No, I think the only role of laser in DME is now to do a focal laser to a microaneurysm, because the rest of all is taken up by the anti-VEGF. And if it is a surgical indication, definitely it will go for a vitrectomy. So focal laser is one thing that is again staying back for management of DME.
In other words, grid laser is obsolete. Now we do laser only in center sparing, not in center, not involving type of DME which circinates, and there is a localized area of this thing with the microaneurysms in the center. So that is, again, this is already told, no? Double layer sign. This is hyperreflective double layer sign. What is the diagnosis here? You can see it's a large choroid, thick choroid, very high, with some pachyvessels. There is a serous detachment, there is a PED, there is fluid, there is hyperreflective fluid, hyperreflective area underneath. Is it blood, this hyperreflective? No, because if it is blood, you will not see anything underneath. Okay, so this is not blood. So what could this be? Pachychoroid disease, only 3-4 are there. One is CSR, one is BCV. So this is basically fibrin, in fact, where there is a PED. This thing is actually fibrin. I will show some other photos also. So this is a sign. What is this sign? There is an area of fibrin, and there is a leak underneath, and this is RP rib, small micro rib with hyperreflective area underneath, and there is fluid. So this sign is called where there is a micro rib, central area, hyperreflective, and around that hyperreflective area. So this is what was called as vacuole sign. We reported in Bindu was there, no? We reported, Bindu reported in retina way back in 2013. So this is a vacuole sign. Because of the high flow of fluid, there will be some clear area just next to the RP, and then so this is another example of fibrin CSCR. A lot of fibrin is there, and that is being shown as hyperreflective area. Okay. So this is my anyone? There is a lesion here. This is an infrared picture. Okay. In infrared picture is just like a black and white picture of the retina. This you can see an area where there is something like this. So this is a. Is it a fluid? There is no fluid because there is no retinal edema. It's just a space, potential space sort of thing, corresponding to this angiogram and this. So this is basically what is called, it's a congenital anomaly, just like a coloboma. It is what is called a torpedo retinopathy. Okay, torpedo. So some people have mistaken it for choroiditis, healed choroiditis patch and all. So the clue is there is no retinal thinning or thickening. So that is why it is usually seen temporal to the fovea. Biju Raju has reported double torpedo, more than one torpedo in these cases. This is another case. Anyone? Diagnosis? What is this? Anyone? Indian Journal we have reported in 7-8 years back. It is called focal choroidal excavation, which is it is seen in some of the pachychoroid disease. It is of two types. One is conforming and one is non-conforming. Conforming is there is no gap actually here. The retinal tissue will be there. Non-conforming will be, there will be some gap here. So some people mistake it as a fluid and treat. Actually there is no need of treatment. This is seen, is called focal choroidal excavation. It is seen in many disease conditions, CSR, PCV, some of the CNVM. Post-treatment, conforming can become non-conforming, this sort of. It is not seen in VKH, okay, this is just a, so this is focal choroidal excavation. What is this? This is a 14-year-old child, don't say that exactly, retinoschisis. So it is not a cystoid macular edema, the structure itself is different, it is schisis. It is schisis. You have to examine the periphery and see whether there are associated features. What is this? Anyone? Dome-shaped macula. The important thing is, here it is a vertical scan. Just look at the scan, where it is going. This and this are all horizontal scans. You will get a large dome-like elevation with something like a fluid. But the vertical scan is flat. That is the clue. You have to do horizontal and vertical scan. So you will get a, that is a classic dome-shaped macula. I have mistaken it for CSR and did angiogram. Angiogram will show some basic staining in that area, which I even treated with laser without any effect. Then only we came to know about this entity. So it is called a dome-shaped macula. This is classic Mactel, I don't have to tell you. What is the sign here? This inner retinal layers are just collapsing into the floor. So it is called collapse sign, okay. So this was also described many years back. Ramiz Hussain had published it in Indian Journal. So this is Mactel. We have around 10 articles published on Mactel. Today I have put one in KSOS official group, latest one published for a new terminology of Mactel in the prestigious journal I, published from Kiran Chandran. So you can go through that, what is the new terminologies in Mactel. I have put in the KSOS official group. Yeah. Then this one, yesterday Dr. George Manet was explaining. So this is what is called multi-layered PED, and you can get cholesterol crystals inside. Pre-choroidal cleft is there. In front of the choroid there is a pre-choroidal cleft, and sometimes you can call it a triple layer sign. There is a cleft underneath this, and then choricapillary neovascular complex. So it is a triple layer sign, you can call it. It is a multi-layer PED, which is seen in more or less inactive neovascular AMD after many treatments. So that is, and what is this? Again, you may mistake it for CSR or any other disease, but you can see that this area inside, and vision is extremely good, 6.9 or 6.5, 6.9 or 6.12. So this is classic OCT finding in a Best disease. Okay. So I almost through. This is actually yesterday, I think, yeah, I have shown it somewhere else also. large yellow area in the center, and there is no macular edema in fact. Unlike CNVM, there is no IRF or subretinal fluid, and fundus autofluorescence shows hyper autofluorescent area. This is a classic adult onset foveal vitelliform dystrophy. Vision will be very good, 6/9 or 6/12, so that is a clue. And if you want to really confirm, don't do a dye angiogram, it will cause some staining, it is very difficult, but you can do an octa which may not show any network in that. Okay, this is classic diagnosis, sawtooth appearance, choroid is not seen at all, and disc edema, and so this is classic VKH. And I have one more last this thing. This is inflammatory cause. There is a large patch, inflammatory, sudden loss of vision. There is irregular RPE. It is called acute idiopathic maculopathy. And the classic finding is there is retinal edema with loss of RPE, pseudopod-like extension and loss of RPE. So this is, but compared to that, this is pigment epitheliitis, where there is a defect in the RPE, which also gradually recurs. So these are some of the examples of acute macular, UAIM and pigment epitheliopathy. There are some differences. I am not going to discuss the details. Time is over. Thank you very much.
Thank you, Dr. Mahesh, for that excellent presentation. Is there any doubt from the audience? The time is almost over. If there is no doubt, we will wind up the session. Thank you all the speakers and delegates for attending the session.